welcome everyone to our monthly Health Law and Ethics Network seminar. For those who I haven't met, I'm Associate Professor Michelle Taylor-Sands at the Melbourne Law School and one of the directors of the Health Law and Ethics Network. I'd like to begin today by acknowledging that I live and work on unceded Wurundjeri country and to pay my respects to their elders, past and present. And I'd also like to acknowledge the different Indigenous groups who are the traditional owners of the land on which we reside. We're recording today's seminar, so please keep your microphones on mute during the presentations, and we'll have time at the end for questions. Today, we're delighted to have two speakers who will discuss Psychiatric Advance Directives and consent to electroconvulsive therapy in Australia, a legislative review and suggestions for the future. Our speakers will speak for 45 minutes today, which will leave about 15 minutes at the end for questions. So our first speaker, I'll introduce both speakers to start. Our first speaker is Dr. Subramanian Purushothaman, who will outline the clinical vignette at the start of that we'll be looking at today. And Subu is currently working as Community Clinical Lead and Director of ECT in Royal Brisbane and Women's Hospital. He's been in the field of psychiatry for the past 20 years, and his areas of interest include ECT, mental health administration, forensic psychiatry, and mental health legislation. Our second speaker today is Dr. Kay Wilson, who will discuss the relevant law in Australia. Kay is a lawyer and a postdoctoral research fellow at the Melbourne Law School with an interest in mental health, disability, and human rights law. Her fellowship project is entitled Mental Health and Public Health, Thinking About Law as Medicine. Kay is author of Mental Health Law, Abolish or Reform, and was a researcher on Emeritus Professor Bernadette McSherry's Rethinking Mental Health Laws and Seclusion and Restraint projects. Kay also coordinates the NDIS and Disability Benefits Clinic at the Melbourne Law School. So I'll hand over now to our first speaker. Thank you.
Thank you, Michelle. I'll just briefly outline the clinical vignette, which was an inspiration to write this paper. As you all know, ECT is one of the effective treatments that we have, but it also has a lot of stigma against it. And if given correctly to specific diagnosis, it can be life-saving as well. With the clinical vignette, we had a patient who had a very severe but fluctuating mental illness, and she was resistant to all the pharmacological treatments, and ECT was the only treatment that helped her. And she, in discussion with her family, wanted to make sure that if she gets unwell, she gets the ECT sooner than later so that she gets better and she can go back to her usual life. And in Queensland, with the new Mental Health Act, patients like Mary can get taken Psychiatric Advance Directive. So she took a valid Psychiatric Advance Directive, and she had capacity and specifically asked for ECT if she becomes unwell, and she specifically said, I want ECT even if I lost capacity, which was the aim of the Advance Directive. But the problem was when she became unwell, we wanted to do ECT, and the ECT involves a short general anesthetic, and for that she needs to fast overnight. And because of the severity of the mental illness, she was not willing to do that. And so the treating team applied to the Tribunal for ECT. There's also a provision for emergency ECT, but she didn't meet the criteria. So we had to wait for about 7 days before the hearing could happen. And then she had ECT, but by the time she stayed in the hospital for longer and she required more treatments. And then when she recovered, she was quite upset that even after taking an Advance Directive and which gives consent for ECT, there was a delay. This is based on her previous experiences that when she gets admitted to the hospital, when she gets ECT, her length of stay in the inpatient unit is shorter, and then because she becomes quite unwell, she needs to be in the high dependency unit, and that's quite traumatizing for her. So that's kind of prompted us to review the legislations about psychiatric advance directives and consent to ECT, which is quite a complex area. Just to give a brief outline about ECT, modern ECT is a very safe treatment, and patients are put under the short general anesthetic, and the treatments are well modified, and they give the general anesthetic and a muscle relaxant so that they don't have any violent seizures or anything like that. And as I said before, if given to the right patient, it can be very useful. The patients respond quite quickly, and it can be life-saving in some instances as well. Now over to Kay.
Thank you, Subu, for explaining all that to everybody. So as you know, I'm Dr. Kay Wilson, a postdoctoral research fellow at Melbourne Law School. And today I'm going to talk to you about Psychiatric Advance Directives and ECT in Australia and give a legislative review and some suggestions for the future. I'd like to begin with an acknowledgement of country. I'd like to acknowledge the Wurundjeri peoples of the Kulin Nations as the traditional owners of the land on which the law school stands, and to pay our respects to their elders, both past, present and emerging. So this is a bit of a roadmap of our presentation today. So I'm going to talk about what are psychiatric advance directives and talk a little bit about electroconvulsive therapy, although Subu's already explained a fair bit to you. A brief history of PADs, the human rights context and some practical issues, a brief history of ECT regulation, and a brief overview of the legislative framework in Australia and some suggestions for reform. So what are advance directives? Well, essentially, advance directives are a form of advanced care planning. And the idea is that they record the person's wishes and preferences when they are well and have decision-making capacity for a time when they may become very unwell and lack decision-making capacity. They're used in end-of-life medical treatment decisions and in also physical health care, but they can also be used in psychiatry. And in a way, they probably could work quite well in psychiatry because most mental illnesses fluctuate and have periods of capacity and incapacity. And because many mental illnesses are chronic illnesses, there's opportunity to learn from previous episodes and treatments about what works, what doesn't, what people like and what people don't like. And they can also potentially reduce anxiety for patients, friends and families because, you know, there's an ability to have some expectations about what will happen when people go into hospital, and promote continuity of care. When there might be different people treating people, they can still see what's on the advance directive, increased patient participation, and perhaps a more individualisation of medicine. Well, I'm not going to talk too much about electroconvulsive therapy because I think Subu's already explained it, but it really just involves passing a small, carefully controlled electrical current to stimulate the brain to trigger a seizure. As Subu explained, general anaesthetic and muscle relaxants are usually administered beforehand. The seizure induces a temporary brain chemistry change, which may improve symptoms quickly, and it's generally used to treat depression, mania, some forms of schizophrenia and catatonia. So why look at psychiatric advance directives or PADs and ECT? Because PADs apply to all forms of psychiatric treatment, but we think that they couldn't be particularly useful for ECT because ECT is a controversial and strictly regulated treatment. Informed consent forms an important part of most regulatory frameworks. PADs are a really good way of recording the maker's consent, refusal, and even their general feelings towards ECT. And research indicates that ECT is probably the most often refused treatment at around 47%. But what we also wanted to show by talking about the clinical vignette and the patient we've called Mary, not her real name, her case, is that it also shows that PADs can be perhaps a way of streamlining treatment for those who want it. So when they are feeling unwell, they can book themselves into hospital and they know that they're going to get the treatment, even if they lose mental capacity. And, you know, they can just get it done, you know, get some relief and then just go back to their lives and minimise disruption. And I think probably when it comes to one of the complaints about compulsory treatment that patients often make is is that it's very disruptive to their life. So this is perhaps a way in some cases for those who do want ECT and want it quickly to, I guess, take control of their illness and help them have the better life. And also potentially avoid the length of time they're in hospital and the possibility of then having restrictive practices and seclusion and restraint and things that they don't really want and that they find traumatizing. Okay, so terminology. In the mental health field, there's always lots of disputes about terminology. There are loads of different terms that have been used for these things in the literature and the legislation. So that, you know, there's living wills, there's mental health advance directives, advanced decisions, advanced statements. The list goes on and on. But what we've chosen to do is to choose the term Psychiatric Advance Directives or PADs, really just for simplicity. I also want to clarify that we're only really concerned about PADs that are recognised by legislation, not informal clinical practice tools like joint crisis plans or wellness action plans, even if they're only recognised by legislation to the extent that clinicians just have to have regard to them. And there are different kinds of PADs, so I wanted to just make you aware of those. So PADs can be used to consent to or refuse psychiatric treatment, but they can also be used to provide information about personal matters, such as care of dependents or pets when people go into hospital, payments of bills, maybe other sorts of preferences like, you know, I only want female staff to be looking after me, or, you know, I just want vegetarian food, or perhaps, you know, when I'm feeling really unwell, can you take away my mobile phone? Those sorts of things. And there's also self-binding directives. So I just wanted to make you aware of that, or what's called Ulysses agreements, which is really based on the legend of Ulysses, who strapped himself to his ship, the mast of his ship, with the idea that he could hear the siren song, but not be ruined by it and be lured to his death, and with the instructions to his crew that, you know, as much as he might be objecting and wanting to escape his chains, that they were to keep him bound and bound him harder. And so I guess this is the idea of also the potential of an advance directive is that it has some degree of permanence and that it may not be changed even if a person later changes their mind. And I think really probably that's what Mary was trying to do when she was setting up her advance directive. She wanted it to apply even if, for instance, she started when she became very unwell, decided that she was not going to fast or cooperate with what needed to be done to give her the anaesthetic. So I thought I'd give a really brief history of the PADs, but just to give a bit of an idea about, you know, where have these ideas come from, how are they evolving in legislation? So I think the first thing to note is that PADs need to be understood in the context of coercion in psychiatry. So if there's anyone listening who isn't familiar with mental health, we do have mental health laws that can force people to stay in hospital and to have psychiatric treatment in certain situations if they lose mental capacity or if they're at risk of harming themselves or others. And I think this coercive context perhaps distinguishes PADs from other kinds of advance directives, but perhaps also gives them a special role in that they also perhaps give patients an opportunity to make their wishes known in a process where their wishes and feelings and involvement may not be very great. So they arose first in this coming out of the anti-psychiatry and civil rights movements in the 1960s and 70s. And the anti-psychiatrists were pushing for the abolition of coercion in psychiatry and perhaps even the abolition of psychiatry itself. They were very critical of psychiatry. In 1964, May Ellen Redford came up with this idea of the will for a living body, similar to what a person might do for their last will and testament for land and estates, but over people's wishes in relation to medical treatment. In 1982, Thomas Skays, a famous anti-psychiatrist, picked up the idea for use in psychiatry. And I think he really saw it as a bit of a compromise, given all the the controversy about, whether psychiatry and coercion should be abolished. And he sort of came up with this idea that that those who wanted psychiatric treatment could use a PAD to give consent in advance, and those who opposed psychiatry could refuse it when they were well. So PADs after that were slowly incorporated into mental health laws across the US, and they were in 25 states by 2006. In 2005, in England and Wales, advance directives were acknowledged and incorporated as part of the Mental Capacity Act. While PADs in England and Wales are non-binding, binding PADs can be made with respect to ECT. So pretty much along the same lines as other illnesses. So I think what's important to point out about that is that there's this sort of exceptional treatment of ECT, that it's treated differently from other psychiatric treatments. And I'll talk more about that later. In 2005, Scotland introduced a similar sort of regime for non-binding advance statements for use in psychiatry. And that's really the model that the Victorian government adopted when we included advanced statements in our legislation in 2014. In New Zealand, PADs aren't binding for compulsory mental health patients, but literature suggests reform might be coming. In Australia, there's been interest in PADs since the 1990s, but legislative reforms for PADs occurred in Australia from 2014 in response to the Convention on the Rights of Persons with Disabilities in 2008. So there's a few potentially quite a lot of theoretical issues with PADs. I guess the first thing I wanted to talk about is coming out of the CRPD is there's been a bit of attention given to PADs because they're said to be a form of supported decision making, and they're talked about in that way. But as Weller points out in 2012, they're probably more accurately thought of as being a kind of substitute decision making, except that the decision's made by the person's self at an earlier time, which is, I suppose, a little bit less objectionable than perhaps having some external third party making a decision for a person. There's a bit of confusion, I think, as to when PADs will kick in. The CRPD committee, which is the committee responsible for monitoring the implementation of the CRPD, says that a person never loses decision-making capacity and really emphasises that contemporaneous will and preferences are always paramount. So under this radical CRPD model, Sholton et al. Say that the use of PADs is very, very limited. They'll only really apply in a situation where the person doesn't have any contemporaneous will and preferences. We don't know anything about them, their will and preferences at all, or in a situation where perhaps what they're saying is just so nonsensical that no one can make any sense of it. So that means that, treatment will be delayed if it is used under an advance directive, potentially till quite late in the piece. Under the idea of a mental capacity with support model, which I talk about in my book, my thinking about PADs is perhaps that they fit better in with that model under the classic idea that you make a PAD when you're well and you have capacity, and then that the PAD kind of acts almost as an extension of a person's decision-making capacity, and they can originally be made in the first place, with support. And then they can be used to both refuse and to facilitate early treatment, and to be able to, get the power of the PAD and harness it in a way that Mary was trying to do. There are also practical problems with PADs. I mean, how do staff ensure that they know that they exist or that they have the most recent version? What happens if a person makes a PAD but later changes their mind? What if a PAD is very old or doesn't reflect technological or circumstantial changes? And uptake is extremely low. So in 2016 to 2017 in Victoria, the uptake was about 2.34%. So why is that? Well, partly because people don't always know about them. I don't think the processes have been really all that publicised. Research shows that uptake tends to be better if there's more institutional support from hospitals and doctors. And maybe some patients think in psychiatry, this is a bit pointless because it's not really binding anyway, so why do I bother? On the other side of the coin, research suggests that clinicians, while they're generally open to the idea of PADs, they do have some ethical concerns. They're worried that people might refuse all treatment, even though that's quite rare in the research, or that people may not have had mental capacity at the time they made their PAD, and their PAD may not be really a valid record of their true will and preferences. So moving on to ECT for the moment, I had to do quite a bit of research about this and a bit of digging because there wasn't that much around. But what I found was that in the 1930s, psychiatrists were experimenting with chemically induced convulsions, and they were also looking at the relationship between epilepsy and mental illness. And by 1938, they were using electricity, and ECT was invented in Italy and really taken up quite quickly, I think, in Australia in 1941. It was invented at a time where there was really no treatment for mental illness at all. So it was really seen to be a big breakthrough and humane, and something that would really give patients who previously, gave them hope to have a life outside an institution. The use of ECT declined in the 1950s and 1960s with the invention of new medications. But as you've heard from Subu, ECT is still being used, particularly if those medications aren't as effective. So in the 1960s and 1970s, the same anti-psychiatry and civil rights movements that gave birth to the PAD, they sought to ban and regulate ECT. And early versions of ECT did cause pain and injury because they didn't use the anaesthetics and muscle relaxants and things that are used now. In popular culture, there were movies like, One Flight Over the Cuckoo's Nest and Ordinary People that created in the public's mind this idea that, there was something suspicious about ECT and that it was being used to punish rather than treat patients. There's also been consumer-led studies which have questioned the efficacy of ECT and perhaps highlighted some of the negative side effects, like particularly autobiographical memories, and also some cognitive deficits that can interfere with basic tasks like reading a book or driving a car. So with all the, public uproar about it, ECT was first regulated in 1974 in California, and that spread to the UK in 1983 and Victoria in 1986. And arguably, as I've been informed by my co-authors, the restrictions are potentially or may be outdated and may not actually reflect some of the scientific advances with ECT as a safe and effective treatment. But I think, given the controversy that surrounds ECT, and I don't think it's treatment as an exceptional sort of treatment, and I don't think its regulation politically is going to go anywhere. I think the stricter regulation of ECT is here to stay. So why review the legislative framework for PADs and ECT? Well, the first reason is that a clear framework for PADs, it resolves legal doubts held by patients and practitioners. It's important to give patients' will and preferences legal effect. It alleviates practitioners' fears that they may be responsible for following or not following a patient's wishes. It provides us with a bit of a baseline about what currently exists in law in Australia. And as we can through comparative legal scholarship, we can learn from variations in different jurisdictions, and we can cherry pick novel provisions for law reform. Although, I don't think law reform needs to be confined to what already exists, but it's a good starting point. And it allows us to consider things like, well, how well does the existing legislative framework support PADs, and whether there should be, special rules for ECT and PADs. Okay, so I'm going to give now a bit of an overview of the legislative framework for PADs and ECT in Australia. And I've had a bit of a dilemma about how to do this all week, because legislative analysis is dry. And it's heavy and it's technical and, you know, it's not very sexy at all. And how do I manage to do this in a lunchtime seminar? So I decided that instead what I'm going to try and do is just give you the tip of the iceberg. So the details about the legislative framework are actually set out in our paper, which has been recently published. And that sets out in it a brief description of the law in relation to ECT and PADs in each state and territory. So I invite you, if you're interested in the details, to, you know, dip into it. You can look at your jurisdiction, or you can look at all the different jurisdictions to get a bit of an overview about what the lay of the land is. And also to point out that it's actually, the paper is actually based on a huge folder of legislation and materials that I've got, and a lengthy comparative table of over 26 pages. So there's a lot of ice that sits underneath the tip of the iceberg. There's also a shorter table in the paper of a few key legislative provisions for ECT and PADs. And I had thought of putting that up on the slides, but even that was very unwieldy and cumbersome and covered lots of different slides. And I just thought it's just too difficult. So I'm just going to give you the highlights and the headlines. So looking at the legislative framework for ECT in Australia, ECT, as I've mentioned, is strictly regulated in every state and territory, except for Tasmania, which is either lagging behind or ahead, depending on your point of view. In most jurisdictions, ECT must be administered with informed consent, except for emergencies or with tribunal approval. There are some variations, but that's kind of the general rule. And some jurisdictions allow ECT to be performed based on consent in a PAD. You know, some don't say anything about PADs, and some say that yes, you can consent in a PAD, but you still have to go to the tribunal. So there's once again a fair bit of variation. In most jurisdictions, administering ECT outside the Mental Health Act is a criminal offence punished by heavy fines and or imprisonment. So it's a pretty serious thing. In the ACT in Western Australia, ECT is banned for children under 12 and 14 respectively. So I just wanted to point that out and note that there are different rules for children and young people, although once again, for reasons of complexity and trying to make dealing with this manageable, we don't really cover the special rules for children and young people in our paper. So an overview of the legislative framework for PADs in Australia. Well, PADs have been legislated in Queensland, ACT, Western Australia, Victoria and South Australia in various forms in a range of very complex mental health, guardianship and power of attorney and medical decision-making regulation. There are legislation, there is regulations, there are rules, there are chief psychiatrist guidelines. And I've got to say, it was a bit of a job trying to pull them all together and make sense of them all. And I thought to myself, if I'm having trouble with this, heaven help a busy practitioner or even a consumer trying to make sense of it all. And that will lead to one of the recommendations for reform I'm going to talk about. So I should note that Northern Territory has very limited recognition of PADs in their Mental Health Act, and it only pretty much says that clinicians have to ask a patient if they have one. It doesn't really say too much beyond that as to what happens then. But in the general advance directive legislation for physical healthcare, it does say that they are non-binding for compulsory mental health patients. New South Wales and Tasmania have no legislative provisions for PADs at all, but there is a little bit of case law. So in the case of Hunter, that established that you could have, drawing on English authorities, you could have an advance directive under the common law, and that case involved refusal of dialysis. So a bright spark tried to create a psychiatric advance directive in Tasmania where there's no legislative provisions for it, refusing psychiatric treatment. But the Tasmanian Supreme Court kind of said, you've brought a knife to a gunfight. Your common law advance directive is no match for the sovereign powers of Parliament and the compulsory powers under the Mental Health Act. So that was not binding. So all legislative schemes that I've looked at require that to be valid, that the person must make their PAD when they have decision-making capacity, and it only comes into effect if they lose capacity, except possibly the new Mental Health and Wellbeing Act in Victoria, which is inoperative until September 2023 and is under an independent review in relation to compulsory treatment, restrictive interventions and PADs. And that act says that you can make a PAD at any time and doesn't refer to capacity at all, although it can still be overridden by psychiatrists if it's not clinically appropriate or if it's just something that they just don't do at that facility. Of course, there's the case of PBU and NJE and the Mental Health Tribunal, the ECT case, which found that only a low level of capacity was necessary to refuse ECT. A few notable provisions. I think a good thing to point out is that a lot of jurisdictions have separate provisions for two different kinds of PADs. So some are a bit more general and flexible, like just a values directive. This is what I like and what I don't. This is about me, providing information rather than any specific directions as to what they want, or which relate to personal matters, you know, like the paying of bills and looking after dependents. Which are generally non-binding. And then there are others that relate more to the consent or refusal of medical treatment. ACT has the most highly regarded model in the literature. People tend to like that model. And it's also been approved by the Productivity Commission. No PADs are binding with respect to compulsory mental health patients in any state. But there is this little provision in the ACT that says that the tribunal can't order ECT if a person refuses it in a valid PAD. And you'd think this might be up in flashing neon lights, like you can make a binding advance directive in relation to ECT, but it's just hidden in this tiny little provision, section 157(1)(c) of the Mental Health Act. And, you know, I'm sitting there scratching my head going, does this mean what I think it means? I think it does. So yeah, that's an interesting one. A PAD can be binding for voluntary mental health patients while they're still voluntary. But of course, if they become compulsory, it can be overridden. And they can also be binding with respect to, you know, general medical non-mental health procedures. There are some other provisions that in the ACT, the treating team is involved in making and having some responsibility for implementing PADs. And Queensland has a process for PADs to be uploaded to the patient's electronic file and for PADs to be completed on discharge. So what we've got is, I think, in those jurisdictions, PADs are just becoming a bit more part of mainstream mental health services and part of the normal operations of those slowly being incorporated. Okay, generally in most jurisdictions, you can make a PAD, but it won't be enforceable if a person is resisting treatment, like what Mary did, without approval from the tribunal. So only Queensland actually gives patients the option to state in their PAD whether they want their PAD to apply if they change their mind, but there's still no authority to enforce it if the person's resisting. I think there's some authority to use physical restraint, but that's not perhaps that practicable. For instance, if you're trying to just stop someone from eating for a certain number of hours before they have their procedure. So I assume they would just use seclusion for that, or just somehow make sure that someone doesn't eat. So there's no law in Australia that would probably allow Mary to make that kind of self-binding directive that she was trying to do. Only South Australia defines consent to anaesthetic as part of consent to ECT. So I just wanted to note that as well, because that was a bit of an issue in Mary's case, because the psychiatrists weren't quite sure about whether consent to the ECT also included the other anaesthetics and medicines as well. So some suggestions for reform. Well, the first one is to try and create a comprehensive legislative framework in one piece of legislation, ideally the Mental Health Act, I think, to reduce complexity. To consider to what extent PADs for mental health should be different to those from physical health. To introduce partially binding PADs which allow patients to consent to or refuse ECT, similar to the idea of what happens in New South Wales and ACT. I think it should be a general idea that the formal requirement should be a bit higher if a PAD is likely to be binding, and possibly even involve some sort of independent capacity assessment or reassurance that this really is a person's true will and preferences. And I think that, yeah, so I think that something has a bit more weight if we feel that the formal requirements are a little bit higher in the first place. And in the ACT, if you do want to do a PAD to refuse ECT, you know, it's not something that happens that easily. You need to have 4 people sign and witness the PAD, and 2 of them need to be from the treating team. You can legislate, I think, also that certain information and supports must be given to people when they're making their PADs, and some legislation actually does that as well. So that could be something that could be more widely put in. I think perhaps there could be better understanding of where PADs are non-binding, of what it means for a clinician to have regard or to consider them, and when overriding them might be clinically appropriate. I think it'd be good to build some more law around that. So it's not just a case of just looking at it and putting it to one side. What do you actually have to think about, and when might it be clinically appropriate? What does that mean? And that patients ought to be able to appeal a clinician's decision to override a non-binding PAD. In the sense at the moment, you know, a clinician just says, oh, you know, I'm not going to follow your PAD, and then gives a patient, you know, written reasons 10 days later. There's not really much ability here, I think, for the patient to say, well, look, I just don't agree with your decision and I want someone to review it. I think that the idea of the involvement of treating teams in making a PAD has the advantage of increasing the chance that, you know, treating teams know about it, they'll implement it, they'll follow it, and it's more likely to stay updated and reduce the risks that it's going to be really old and outdated. So you can check with people at regular times, you know, on discharge or whatever, you know, this is your PAD, do you still like it? Do you want to change it? I think the making of a PAD can be used to increase communication, access supported decision-making, and build therapeutic alliance. I think the use of independent mental health advocates, which is becoming more and more incorporated into mental health legislation and systems, especially, you know, a big part of the Victorian Royal Commission, and perhaps even access to independent legal advice, can be used to address power imbalances. I think a patient should be able to indicate in their PAD if they want to make a self-binding directive, which they want to be enforced, and in what circumstances, like in Mary's case. I think consent to ECT should include anaesthetics and everything necessary to safely give ECT. Now, as lawyers, we would say, well, consent to ECT should be interpreted broadly and includes all those other things. The problem is you have practitioners and other people looking at it, and they just feel better if it's spelt out. I think the use of a prescribed form to create a PAD can be quite useful, because it does create a prompt for the makers to address certain issues they may not otherwise think of, like, what do you want to happen if you later change your mind? And really think through, you know, what they want from their PAD, and to be able to express and indicate that. I think the tribunal should definitely be involved where there is doubt or dispute about a PAD, and that legal protection should be given to clinicians when following a PAD, you know, provided they're doing so in good faith and without negligence. So in conclusion, I think that given the technical complexity and inadequacies of the legislative framework in Australia, it's not really surprising that PADs are underutilised. I don't think that PADs will ever replace involuntary detention and psychiatric treatment in mental health law. I think there will always be issues with people who have first episodes. They're not going to have a PAD in place probably. I think I'd be surprised if you'd ever get uptake levels to 100%. But I think they provide an interesting supplement to mental health law. And I do think there is tremendous scope for reform for a legislative and systemic framework which is less coercive and more empowering and supportive of patients' wishes and preferences, while also addressing clinical concerns. So for further details, these are the details of our paper that's recently been published, which is the same title as this presentation. And I guess I'm ready to take some questions, and also that's my email if people want to email me questions.
Thanks, Kay. So we'll open it up to questions. People are welcome to either put their question in the chat function or just raise their hand on the video, either in person or using the hand function. Chris, I think I just saw you raise your hand. Chris, thanks.
Yeah, thanks, Michelle, and thanks, Kay. That was a really, really interesting talk. It's really interesting from a philosophical perspective, which is my background, because
Yeah, I've got a problem not really hearing what you're saying. It's cutting it out.
Okay, hold on. Yeah, so in philosophy, we normally make this distinction about autonomy. So autonomy is this general thing that we need to respect, but it normally comes in two parts. So there's normally something called self-determination, which is your ability to make these really weighty decisions in your life so that your life is sort of going the way you want it to go. You're the author of the major decisions in your life. So this seems like the type of thing that is lost in some of these episodes. But there's this other level of autonomy, which is basically sovereignty, which is basically like, well, it's your body, you're the boss of it. You know, I control what I eat, I control what goes into my body. And that's sort of something you don't really lose. You know, children have that. You know, it's a sort of more basic capacity. So it seems in what's going on here in one of these cases is you're getting a clash between someone's self-determination, which they've made prior, and someone's immediate sovereignty. And I'm just wondering, in the law, it's a bit confusing because when they talk about they lose decision-making capacity, well, for me, that could maybe mean two things. You lose the capacity to make those really weighty decisions about how your life is going and those weighty decisions, versus you lose the capacity to make decisions about your body and what goes into it. So yeah, I'm not sure if this is a question or more of a comment, but it seems in some of the legislation, and you talked about like this radical CRP model where it's all about your, you know, what you feel at the moment. Well, that seems to be really just focusing on sovereignty. It's like, well, I've got the capacity for sovereignty, but it's sort of not recognized, and you're losing this sort of higher level capacity to make informed decisions. So I'm just wondering if that is ever sort of reflected in the literature, or if that's, I don't know, if you have any reflections on that.
Yep, I do. I refer you to my book. Yes, look at all those issues in detail, and it's what really the clashes that you've identified, a lot of the clashes that occur over the whole idea of coercion in psychiatry. Certainly the sort of more radical CRPD model really takes a completely different basis, and yeah, is saying that we need to give more respect to sovereignty over the traditional sort of ideas of autonomy in decision making, and so yeah, I guess it's just a difference in emphasis, and they kind of deny this. So they dispute the whole idea that people have mental capacity at all. They say it's not really a case of having mental capacity or not having mental capacity. It's really a matter of degree, and that ultimately people just need to be given support to help them make decisions. You know, it's more a case that maybe some people require a higher degree of support than others. But that raises all sorts of questions about, do we get to a point where if someone's getting 100% support, is it still their decision? Is it really just a substitute decision that's being made? And it also raises issues. For instance, they also say that a person can go, no, I'm good, I don't want any support at all, and just reject all support. So what happens in that situation where we think that, well, maybe a person isn't really thinking about things well, and they might need more information or to think things through some more. So yeah, it's really complicated, and these are the debates that are happening through the whole area. I suppose the people sort of who think that mental health law should be abolished kind of take the view that the loss of sovereignty is too high a price for potentially saving health and life.
I think that's really helpful. I'll have to look at your book, but it seems like there will be cases where the degree of sovereignty infringement is different. So in ETC, if you've got to not let them eat and you've got to, you know, put them in, it seems like it is quite an imposition on someone, sort of basic basic sovereignty. So I can see how it's like a tricky balancing act there. I also just have a really quick question. I think it's probably better for Subu. Do we know how ECT works? Like, I take it there's good evidence that it works, but do we know the mechanism, like how it is working, like what's it doing to the brain that gets an effect, or is it just a bit of a mystery at this stage?
That's a good question, Chris. I want to highlight the analogy of the complexities involved in how we know whether how it works. ECT works in multiple different ways, but how it works for each patient, we don't know the exact reason. Like, we know that it improves the, there is a barrier between the body and the brain. And then if you, like, for example, if you take any medications, for it to reach the brain, it has crossed through multiple barriers. The ECT improves the permeability of the barrier. It improves the cerebral blood flow into the certain parts of the brain. We know that definitely happens. ECT also can stimulate the generation of certain neuromodulators. But these are all multiple mechanisms of action that we know that it can do. But if you give me a patient, like a consumer A, who has a depression, how ECT works for that person, we don't know. But I'll also highlight that if you take any other organs in the body, we can see how it works. We can take a piece of it and then see how it works under the microscope. But brain is difficult. And it is connected by, like, if you stimulate one part of the brain, multiple other areas will stimulate. For example, I usually say heart has 4 chambers. There is only finite ways that heart can work, and we can see how it works. With brain, we can see to some extent, but we don't know because of millions of connections. So to answer your question, we know that ECT works in multiple different ways, and we know that each mechanism of action, but how it works for each patient is difficult to know.
Okay, that's super interesting. Thank you very much, both.
I might just, while we're sort of waiting for any other questions, just reiterate, yes, that issue about sort of higher order or critical interests that Chris raised, and I guess Ronald Dawkins describes it, higher order or critical versus experiential interests. And I mean, that must be a really challenging thing from a clinical perspective, Subu, in terms of the person in front of you and how you approach that when someone is refusing something that they've previously, perhaps if they don't clinically have been assessed as not having capacity, but are resistant to something that they've previously said they would like to have, such as ECT. And I'm just curious as to what is there a sort of a dominant view, clinical view, in terms of dealing with the person in front of you, or the and their experiential interests at that time, or giving priority to the high order interests that might have been previously pen to paper?
Yeah, it's a very complex situation. Like, if it is for any other treatment, they have said yes previously, and if they don't have capacity, it's very, like, from the clinician's point of view, we are very happy to give the treatment because they've given consent. But when you take ECT, it is a regulated treatment, and under the Mental Health Act, it's got a lot of stigma against it. And then as outlined by Kay, the consent under the Advance Health Directive, it's very difficult to ascertain whether it includes everything for ECT. In this case, this Mary was not willing to fast, and it is very critical that she fast before ECT, but enforcing it just because she was given consent is difficult as a clinician, because we might be restricting her food intake, and then that means that we are further traumatizing her, and then she would not come into the ECT, like the suit, and then we need to have the security to bring her in. It's all difficult to enforce just with an Advance Health Directive, because we are from the consumer's point of view, we are restricting her food intake. We are forcing her to come into the treatment room. It's very difficult as a clinician to use that higher order thinking, or the capacity, that the consent that she's given previously. If it were like, let's say, if there is a medical treatment like dialysis, or you're going to give medications, or you need to give intravenous fluids, it's easy. For medical conditions, for mental health conditions, on one hand, we need to enforce the treatment, but on the other hand, we also need to limit the use of restrictive practices, which is traumatizing for the patient. I think that's where the dilemma comes in for the clinicians. Thank
you. Yeah, I think it must be really tricky because it's very, I guess what gets lost in the overall picture is the fact that ECT is a restricted treatment under the law, but other treatments aren't. So what sometimes gets forgotten that if you don't, as you've pointed out, it's really difficult to enforce something if someone's refusing it at that time, but under the Mental Health Act, you can actually enforce. There could be more restrictive things going on, such as seclusion and extended stay, which is sort of the point of the vignette that you set out at the start of the thing. So it's, I think there is I think I agree with Kay that probably for a combination of reasons, ECT as a restricted intervention is here to stay. But yeah, I can see how it clinically makes it very, very tricky because it doesn't necessarily prevent restrictive practices being needed to use for other means and sometimes perhaps for a longer period of time. So yeah, I think that's a very difficult area. Thank you.
Sorry to jump in. Can I just ask a clarifying question, just following on from yours, Michelle? So if someone is an involuntary patient in a psychiatric ward, is there any cases where they will have ECTs sort of against their will because it's just the clinicians think it's the only sort of treatment that will help them?
Yes, they can with tribunal approval.
Right. Okay.
And that's ultimately, in Mary's case, what Subu had to do. So he still had to restrict her from eating. The difference is that he waited 7 days and got approval from the tribunal to do it. Whereas perhaps if we had something in the Act that says that you don't have to do that, and if Mary's perhaps specified in her PAD that that's what she wants to have happen, that kind of gives you a stronger, I think, moral and legal basis to go, no, we're going to, enforce your PAD and we can do it. We don't have to necessarily go off and get approval from the tribunal first because you've already given us consent. Because of course, if Mary did have capacity, she could just walk in and give consent to ECT straight away, and that wouldn't be a problem. So yeah, contemporaneously she can consent. What we're dealing with is the fact that then, she may become unwell and she's putting something in place knowing that that might happen with her PAD.
Thank you.
Paula has her hand up. Thanks, Paula.
Thanks for the presentations. I just wanted to ask about the Victorian review that you mentioned, Kay, and what you think might happen with that review in terms of the ECT and PADs that you're talking about, the likely direction that the review will go in.
I can't say. I really don't know. It may be something that, I did speak to Justice Marshall, who's heading it, and he was interested, I think, in hearing from people at MLS, but he'll also be interested in hearing from a whole lot of other people, and that will also depend on what the rest of the independent panel thinks as well. He'll consult with them when they start, I think, at the end of this month. I think the general idea in the so the independent review comes out of the Royal Commission, and the Royal Commission in Victoria is really about, or talked about in a general sense, really reducing coercion in psychiatry and making it a last resort. So I think that that will be something that will guide the independent panel in making its recommendations as to what will happen. But it might also depend, because they'll also be looking at compulsory treatment generally, not just PADs, that's only part of it. And they'll be looking at use of restrictive practices. And the Royal Commission has said that, quite controversially, it's been in the papers, that what should happen is that use of restrictive practices should be phased out in 10 years. And certainly there should be work done to reduce the use of restrictive practices as well. So we're definitely moving away from coercion in psychiatry here in Victoria. So it will be interesting to see what comes out of the independent panel, because I guess part of the reason why this isn't in the legislation already is because these issues are really difficult and complicated, and the Royal Commission didn't just sort of presented some general guidelines and didn't actually specify exactly what the law should be. And when they were trying to put into place and draft the new Act, I think the parties all felt that more work needed to be done to look at this in a more detailed way, and that more time was needed. But yes, I think it'll be very interesting to sort of see what happens, because as you know, the panel has on it, the emphasis is to have a lot of people with lived experience on the panel, although there are some psychiatrists. So it'll be very interesting I think there'll certainly be a push to really move away from coercion, but you know, then there's always those practical issues about you know, that as much as coercion can be traumatizing, sometimes it might be necessary to preserve people's life and health.
Thanks, Kay. We have time for one more question. Does anyone else have any final questions? If not, I just had a small comment. This is just really a small point, but in that vignette, I noticed one of the reasons why it couldn't come before the tribunal was it didn't satisfy the criteria for urgent ECT treatment. I just wonder whether an additional sort of recommendation might be to broaden the criteria for urgent ECT applications to include reference to PADs where that's been mentioned, because obviously the criteria as it currently stands has to be, I think, significant, substantial suffering or potential death, but maybe you could also, that criteria could be broadened to include PADs that might cover a case such as Mary's case. So instead of waiting 7 days, it could come to the tribunal within a day or two. Might change the shape of that.
Yeah, no, look, we were definitely talking about that when Subu and Uday first came to me, and I sort of looked at what they were saying, and I sort of said, oh, well, can we just, you know, make the tribunal hearing quicker? So that's certainly part of it. And I just think it's very, that's a tricky thing as well. I think probably that's one thing that can happen, but then on the other hand, I've heard things from consumers complaining about that, you know, ECT hearings are brought on too quickly. So there's that other side of it as well. Then I suppose the other thing is, well, what really, if you've got a good PAD and a recent one and one that you're confident in, what exactly does the tribunal add to that? Potentially, if they've got a good PAD, they've got someone who's lost capacity, and you've got people making that application, well, what are they going to do? They're just going to rubber stamp it, really, aren't they? But on the other hand, it was a difficult question because Subu and Uday, I think they were a bit ambivalent about the tribunal. On the one hand, I guess they sort of saw it as additional red tape, but on the other hand, they kind of liked that going to a tribunal, I guess, it kind of covers your bottom a bit. You've got a tribunal order saying, yes, you can do this. So from that perspective, that is something that they liked. And Uday sits on the tribunal in Queensland as well. And he said, look, you know, sometimes there are people who overuse ECT, and maybe that's not a bad thing. So yeah, that's another potential way. I think it will never be as quick as just being able to use a PAD and just do it straight away. I think there'll always be time that will be taken to get the tribunal together. People are busy. They can't just drop everything and do it. So that there will still be some delay. I guess the question is how much delay?
Yeah, thank you. Look, thank you very much. That's been a fascinating presentation, and well done for consolidating and synthesizing such a complex area of law. So thank you both, Subu and Kay, for your wonderful presentations today. And thanks everyone for joining us. I'll just see if thanks Paula. We've just put in the chat the link to the HLEN seminar, so you can get information on the next month's seminar. And just to let you know, it's on the 8th of November, I think. That's because the second Tuesday, it's on the second Tuesday due to the Cup Day weekend. So if you're interested in the next seminar, have a click on that link, and there's also another link to sign up if you want to join the HLEN mailing list as well, if you're not already on that. But thanks again, everyone, and thank you so much, Subu and Kay, for terrific presentations today. Thank you.
Thank
Bye-bye.
you. Bye.